we're going to get started. I'm going to shut the chat box off. If you could just be sure to enter your, hi, New Jersey, be sure to enter your questions into the Q&A, and we're going to get started here. So this is Carol from STS. This is the General Thoracic Surgery Database monthly webinar for September 8th. On the line with me from STS, I have Addie Dolan. Sydney Clinton, our data managers that we have joining us today. We have Katie Lothrop and our STS General Thoracic Clinical Consultant, Ruth Rowley, who manages our FAQ mailbox. And then from iQVIA, we have Melanie Bent, Joe Brower. Oh, I forgot. And Melissa Clark, who's not from iQVIA, but you all know Melissa from Michigan, and Michelle Choi. So thanks everybody for joining. Just a few STS updates. Ruth has some education for us regarding questions that she's received in through the FAQ mailbox, which I think are going to be very helpful to a lot of, to most everybody joining. And then we'll hand it over to Joe for the iQVIA update. And then we'll turn it over to you all for user feedback and Q&A. So for General Thoracic, the August training manual was posted. The September main training manual, I'm assuming that will be coming soon. The 2020 analysis rerun results are expected back in mid-September, so we expect those back shortly. And then the spring 2021 harvest is in analysis at DCRI. We're expecting that file back from DCRI next week. Once we get that file back, it takes about 1 to 2 weeks for iQVIA to QC it and populate it into the dashboard. So it's still going to be a few weeks for that spring 21 harvest to be available to you all. The fall 2021 harvest is scheduled to close on September 24th, and the opt-out for that harvest is Tuesday, September 28th. All right. The other update is the AQO, the Advances in Quality and Outcomes of Data Managers meeting. Registration is open. We have over 800 folks already signed up to attend. So if you haven't signed up, please go ahead and get registered. It is free for folks holding these roles that are listed on the website. And I'll show you where that is listed on the sts.org website after our presentation, if we have time, so you all know where to go. All right, now I'm going to hand it over to Ruth to go over the STS FAQ Inbox education for the month of September. Ruth?
Perfect. So just a few clarifications. So sequence 740, pulmonary function test performed. It says in the definition that PFTs are part of the NQF measure set. And so I got a question asking which measure set it was part of. So I just wanted to show you all where those measure sets are kept so that you can find them moving forward. And then I'll give you a little bit of detail about this specific one. But the screenshot down below sort of shows if the NQF measures for all 3 databases are kept under the Quality and Safety tab, not the Registry tab, but Quality and Safety. And then there's a long list of all of the performance measures, and you can click into each one of those measures and get more information about what makes them up. And so the next slide is just images taken from this measure. So PFTs are part of the NQF measure 3294, lobectomy for lung cancer composite score. So the FEV1 is part of that composite score. And then I've been asked, what are the valid exclusion criteria? So patients are excluded from the composite score if they're not an elective case, if they have an occult like a TIS or stage 0 tumor, if their ASA class is 6, and if they're missing data for age, sex, or discharge mortality. So previously, when you entered, like if you said patient does not have PFTs, you used to be able to say urgent or emergent status. Those cases are still excluded from the analysis because of the way that you enter the status at the time of the operation. So you're already entering urgent, emergent, elective, et cetera, palliative. The only ones included in the analysis are still the elective cases. So no change, even though you're not clicking that box still under the PFT measure. So a quick run through of how to code a patient that's discharged to hospice. This is something new for this version. So patients that are discharged to hospice are considered a mortality, but the way to go about it is that when the patient is discharged, you're going to code yes to sequence 4200 still in hospital, even though the patient has been discharged to hospice. The reason that you do that is to exclude the case from analysis until you have a mortality date to be entered. So you'll follow the patient until you have a date of death, and then you're going to go back into the record. If you want to go to the next slide, Carol. And you're going to recode sequence 4200. You're going to change it to no, and you're going to put in the discharge date, and then you're going to put in the status and the mortality date. So now that case will be included in the analysis now that you have a mortality date, and it will be counted as a mortality. Some of the child fields won't open up when the hospital discharge status is coded as discharge to hospice. So quite a few questions won't have to be answered. Things like discharge location, discharge with chest tube, HOMO2, readmit, substance use, screening and counseling. None of those fields are going to open up. You won't have to code answers for those with a discharge to hospice status. I've gotten a few questions about PEXIs lately. So a pneumopexy is where they essentially are attaching one portion of the lung to another portion of the lung, generally to prevent torsion of a remaining piece of lung after resection is performed. There is not a procedure code for PEXI. It's essentially just a staple line attaching two things together. So you don't need to code a pneumopexy as a concomitant procedure. I've gotten several questions about where to code electromagnetic navigational bronchoscopy, or some sites call it Super D, or CT guided biopsy, or just straightforward transbronchial biopsies of lung masses. We aren't collecting that information for version 521.1. So the only information that you collect under clinical staging methods is that Harvest code number 5, invasive mediastinal staging performed. So even though you'll see EBIS under invasive mediastinal staging, you wouldn't capture a transbronchial biopsy of a lung mass under that invasive mediastinal staging section. So you won't input that information anywhere, which is a change from the last version.
Thanks, Ruth. I'll go to the next slide in a second, but Kathy Falk is having a hard time hearing you. I just wanted to say I had to turn my volume up. So if you're having a hard time, and I'm not trying to be funny, obviously you turn your volume up, but I did have to turn my volume up, quite a bit. So try that, Kathy, if it doesn't work. But Ruth, maybe, I don't know if there's an adjustment on your side that you could do or not, but
I'll try this. Is this better?
I think I can hear you fine, but she was having an issue.
Okay.
Thank you.
Yeah, no problem. Sorry. Okay, what patients are part of the star rating for lobectomy? So this information is on the iQVIA website in the library. I also copied and pasted this information to the front of the training manual, so it's a little bit more accessible than having to go to the iQVIA library and log in separately. So the STS lobectomy patient population for your star rating, they have to have one of those 4 categories of disease, and then it has to be one of the 2 primary procedure codes listed. So for example, something like a sleeve lobectomy is not included, or a bilobectomy is not included. It's really just the open and then the VATS or robotic single lobes that are included in that star rating. And then for categories of disease, the metastatic lung cancers and solitary pulmonary nodule are excluded. So that's why it's always important to code your category of disease based off your final pathology report so that all of those cases get captured in your star rating. A couple more words on lung tumor metastatic. So the code C78.00 lung tumor metastatic includes metastatic disease to the lungs. So if you have the solitary lung met from the prostate or breast or wherever, and they resect it with a curative intent, that resection does not have to be included because it's a metastatic lung tumor. it's not primary lung cancer. Metastatic lung cancer also falls into this category. So if it's metastatic disease from one lobe to another, you would not, that would be coded as lung tumor metastatic. This excludes synchronous primaries and new primary lung cancers.
That was a really great update, Ruth. I'm sure that there'll be questions coming in on that. Thank you so much. I learn a lot every time I hear you speak, so that was really helpful. Thank you. Now we're going to hand it over to Joe Brower for the iQVIA review. Joe. Oh, Joe.
I'm here. We had trouble, I remember once with having my fan blowing in the background, and I was quick reaching over to turn it off before I unmuted.
No problem. No problem.
All right, we do have a few items to get into today. So these are a list of known issues that we are currently working on. Do not yet have a release date for these items, but they are under review. Starting with items related to the uploader and direct data entry validation checks. STS 7157 for direct data entry users. We have received reports that the current critical errors on the form for direct data entry are cumbersome and can disrupt the site's workflow. So we are working with the STS to address these concerns. STS 7250. Some variables are currently restricted only to allow for 1 decimal place, and we are working to update these so that the validation checks allow more than 1 decimal place for those variables. On the risk-adjusted dashboard report, the number of operations and mortality, under operative mortality, the number of mortalities variable on that report, STS 6921. The total number of mortalities displayed is currently correct, but the case list drill down isn't displaying all of the cases. And so we are working on a solution to correct that. On the STS NIS comparison report, STS 6927, we have received reports that the STS mean length of stay appears to be incorrect. And so we're working with DCRI and the STS to confirm the correct calculation information for that section of the report. And then the missing data summary report on the risk adjusted dashboard, STS 6817. We did receive a report that a site noticed that many records were showing that the missing forced expiratory volume performed variable was missing, even though the data was present at time of harvest. So we are reviewing the code and making adjustments so that that is reflected correctly. Slide. There we go. Let's see. So on the participant dashboard, that's the non-analyzed dashboard, STS 6995, we are looking into an issue where the percentages displayed in the report on the website are different from the same report when it's exported. So we're looking to see why that's happening and get that updated so that the values match. And then on the missing variable report, a few items, STS 7050, the MVR is incorrectly flagging the LFU date and LFU more stat variables as missing when they are not applicable based on the demographics form version. STS 7100, for version 5.21.1 records, the MVR is incorrectly flagging the race multi-variable as missing even when it has been answered. And finally, STS 7278, we are going to be making an update to the MVR so that it will begin flagging the COVID-19 temp code and temp date fields when those are missing. And it's the end of my notes, so it should be under the slides. Great. So as hope there was nothing else. So as usual, if we didn't cover something today that you had reported, please rest assured that we are working on it, and you are welcome to reach out in response to your ticket, your open ticket, to request updates on that if need be. And then the usual reminder that we are still looking into additional items to let you know about for the upcoming user group call.
Wonderful. Thank you, Joe, so much. That was very informative. So we have the iQVIA support plan, which we're all very familiar about. If you have any open tickets that you'd like iQVIA to look into, please include your 5-digit participant ID number and your ticket number, and iQVIA can check that out while we're on the call. And then Resources, the STS National Database webpage, STS tech support at iQVIA.com, phone number, and other resource documents that are posted on the STS website. Leanne's information, ljones@sts.org for the congenital and general thoracic databases. And then if there's any questions related to operational type questions, you can email the stsdb@sts.org. Upcoming webinars, September 22nd at 2:30 p.m. Central is the user group call. New data manager webinar. If you're new to the general thoracic, if you have new to general thoracic, this will be a great way for you to get acquainted with the different resources and some high-level abstraction tips. For seasoned data managers, it's very good as a refresher. Things change often between versions and as the years go on. So if you're available to join this webinar, please do so. We're having it for those of you who went to AQO previously. You'll know that we had new data manager webinar early in the morning of the day we had general thoracic presentation. So instead of doing it with the AQO this year, and probably going forward in the future when we get back to live meetings, we'll have this new data manager webinar prior to AQO, just to kind of get everybody up to speed with different resources and functionality of the database prior to AQO. So you're kind of on a level playing field and don't feel too far out of the loop when we start talking about different things on the AQO presentations. The monthly webinar in October was scheduled for October 13th. It's been canceled because that is the week of AQO. So we will not have a monthly webinar for general thoracic in October. So next webinar, September 22nd, new data manager webinar on the 29th. And then we're going to go to open discussion. But before we do that, I wanted to show a couple resources on the STS page here. Let me get rid of all this junk. Okay, so I'm at sts.org, and I know that the print is probably small. I don't know why it opens that way. This is sts.org. I just want to go through a couple things. The first is what Ruth was talking about regarding the performance measures. Those are located under quality and safety. Because our quality, we have a QMTF task force, which is our quality metrics task force, and they're the ones who use the data that you all submit to develop these performance measures, which end up getting validated by the National Quality Forum, or NQF, and then they become NQF measures. So NQF uses our data to assess these various outcomes. So I just clicked on performance measures. We have a bunch for adult cardiac. And then general thoracic, we have the 3 measures down here. The one is morbidity and mortality for lung resection for lung cancer, participation in a systematic database for general thoracic, and lobectomy for lung cancer composite. And the measure type is listed if they're outcomes, structure. There's also process measures. Specifically, we have those in adult where we're looking at like pre-op medications and things. But for general thoracic, we have 2 outcome measures and a structure measure. If you click on this, it's going to give you the description of the measure, the numerator, and the denominator of the measures. So there are your NQF measures that Ruth was talking about. If we go back to the STS homepage, and I want to go into my registries, I just want to do a quick navigation of the STS National Database Registry. You have your 4 tabs here for each registry. Before you even get into those registries, though, there's a lot of information right on this page. If you're looking to add folks onto your registry, for example, AQO is free for all of those different roles. And if you're not sure who holds what role at your hospital, or you need to add some folks on, maybe you have abstractors who are not listed on your account, that you'd like to get free access to AQO, you're going to have to fill out a participant contact form. And those are down here. I might be off. Hold on. Course. I'll show you where those are at. So information on joining the database. Then if you're interested in adding in a participant, you're going to fill out a participant contact form. That's one of the lists under the important resources list provided under database forms. Let's just go through these in order. I'm sorry, I got a little off there. So join the database will provide you general information about joining the database. We also have information about the different vendors that are certified for which registry and which versions of those registries located underneath join the database. All of the live webinars are posted here with the recordings are available and links to the General Thoracic YouTube channel. Your FAQs go here at the clinical questions. And then under important resources, a few things to point out. First is the harvest schedule and information. So this gets updated as we make changes or we're able to solidify some of these dates when data is coming back from DCRA and we have a better idea of when those reports are going to be available. But this is where your harvest close information is available. And Ruth will go over all of this on the in more detail in the new data manager webinar. The other thing that I think is important is, especially right now, is these two links. We have the database forms, which contain the participant contact form. So if you need to add somebody onto your site, you'll need to fill out this form to get them added and update their roles. Or if you need to remove somebody who has access at your site who no longer may be there, you'll need to fill out this form. The reason why that form is important is because for AQO, which is this Advances in Quality and Outcomes of Data Managers meeting, this is where you're going to go to register. Registration is open. We have the detailed agenda here. If you scroll down, you'll see we are offering CEs, which is really a great opportunity. You get all this free information and you get a bunch of free CEs. So that's good, especially if you're nursing in a state that requires continuing education. You will register here now if you're not for general thoracic, and it'll take you to the registration pages. These roles under this bullet point here are the roles that will receive free admission into AQO. So you just want to make sure that you hold one of these roles, or the folks at your hospital who are abstracting are associated with one of these roles, so we can offer them the free admission. If you're not sure who holds which role at your hospital and you want to verify, you could email Addie Dolan, and I'll ask Addie to put her email in the chat box if she's available to do that. And Addie will be able to kindly provide you with that information. Be patient because Addie's a busy person, so she'll get back to you as soon as she can. So again, to register for AQO, it's in two spots, but I would go under registries, scroll registries, STS National Database. And then scroll down here under important resources for advances in quality and outcomes. A couple other useful information is here. So I wanted to show you those. I wanted to show you where to register, and I wanted to show you the NQF measures where Ruth was looking at that information. So, and I think we're going to go over to the Q&A now to answer some questions. And I'm going to do my best. I might not know all of these. If there's specific clinical questions that you have, we're going to instruct you to please submit those into the FAQ mailbox, because oftentimes those questions need to have core group review and or surgeon review. So the FAQ mailbox is the STS National Database, and this clinical question, ask a question button will take you there. So are you ready for some questions, Ruth?
Give it my best shot.
All right, here we go. And Melanie and Joe, can you just remind me why is the 2020 analysis being rerun, and what reporting period does this affect? So this impacted fall 2020 and spring. Melanie, you're going to have to jump in here if I'm wrong.
Spring 2020, both. It was spring 2020, fall 2020.
both of the 2020 reports, and it had to do with thresholds that were being applied at DCRI incorrectly. So that data is being rerun and will be repopulated. Additional notification will be sent out to sites. We're just waiting for some finalization from DCRI on the total impact of everything. So once we have that, we'll send that out, and that's the areas. Anything to add to that, Melanie?
No, that was it.
Okay. Ruth, I'm going to let you take this question from Mary Cook. Is the star rating population still only stage 1 cases?
I'm trying to pull up my last harvest report to take a peek at all the information in there. I don't think that it's only stage 1 cases, but I don't know. Can you confirm that, or someone from iQVIA that does the star ratings?
This is Katie. It's not just stage 1.
I thought it's always been lobectomy for lung cancer. So like the screenshot, it just excludes non-elective cases, occult stage 0 cases. It's that population. Here you go. Star rating for lobectomy. It's this group. So it's not necessarily stage 1. There is a report that was in the harvest report that did look at stage 1 lung cancer resections, and it would give you information about like what percentage of your cases were minimally invasive, et cetera. That was a different report than your star rating report. Does that sound right, Katie?
Yes. Yeah, I think the only thing different, the criteria for the regular lobectomy, like the lobectomy compared to STS composite that we have, that one, or not composite, but that score versus the actual composite score. The difference is there's an additional exclusion of patients, which we already talked about with the occult or stage 0 and stage, and an ASA class of 6, which
6.
never happens. So yeah.
Correct.
Great. Okay, thank you, Katie and Ruth. Next question, Ruth, I think you could take this one. If a patient is discharged to hospice once they die and we go back into the record to code it, what date is the discharge date? And I'm just going to pull up the DCF so we can all see this together here. One second. This is kind of a new idea behind that was applied to version 5.21, and it's something that we're doing throughout all the databases as we're going through upgrades related to these patients who are discharged to hospice. So let's see where the heck it starts. Here we go. Okay. So the question is, if a patient is discharged to hospice once they die and we go back into the record to code it, what date is the discharge date? The date the patient left the hospital or the day they died? So I'm just going to leave it at what date do we use for the discharge date? And what is the discharge status? Why do we need to go through these extra steps?
So the discharge date will be the date that they were actually discharged.
From the hospital.
Correct, from the hospital.
From the acute care stay of the hospital, right?
Correct. So when you change your patient still in hospital from yes to no, after the patient dies, you're going to put in the actual date that they were discharged to hospice, whether that's to home or a hospice facility. You'll put that date in hospital discharge, and then your status at hospital discharge will be discharged to hospice. And then none of those fields in that box, this large box, none of that stuff is going to open, because that only opens if discharge alive, last known status alive, or discharge alive, died after discharge. So you're not going to pick either one of those. And so then, and then here, you're going to enter your mortality date for discharge to hospice.
Mm-hmm. Yep, that's great. And I think the reason why we're having you do these extra steps is oftentimes patients are discharged to hospice, and although most of them die, are expected to die, fairly in an acceptable amount of time. Sometimes patients might live longer than what would be allowed for maybe like the 30-day follow-up, or if we're, getting close to a harvest close, things like that. So you don't have missingness on the mortality date. The recommendation is to code these patients as still in hospital alive until they expire, so you don't get dinged for missingness on these fields. Do you think I got that? Did I get that correct, Katie? Katie or Ruth, do you guys have anything to add? Okay.
Nope, that's exactly why.
Okay, thank you. Here's another one for you. Is there a place to abstract current carotid artery disease or previous cardiac or carotid endarterectomies?
We were just talking about that earlier today,
We
Carol.
share
I
words like
think-
they were listening to our conversation.
So I think our conclusion was no, there is not a place to code carotid artery disease or carotid endarterectomy. However, if the patient had a TIA or a CVA, you would code either one of those. But the discussion surrounding carotid artery disease was that they did not want to capture that for this version.
Thank you. Okay, next question. Since pylorus management 2380 and J2 placement 2390, so let's go there. These two questions is what we're talking about, and we are in the esophageal procedural section. Since pylorus management and J2 placement are in the esophageal cancer section in the new version, does this mean that we don't have to put those down in the list of procedures performed, or should we continue to add those along with their CPT codes in the procedure list?
So you do not need to include those under the procedure list. They were intentionally removed and elected to be captured in this esophagectomy section. Some cases or some institutions do a decent number of esophagectomies that are not for cancer. And if you're doing an esophagectomy not for cancer, this whole section is not going to open and you're not going to be able to collect that data. However, you don't need to include it in the procedure section.
We're only interested in it for esophageal for primary cancer cases, correct?
Correct.
I take notes, mental notes as you go through these things, Lumetics has created a 5.1 minor form. We have been told that if we do minor cases, then we have to collect all the data on the full DCF because there is no minor form anymore. Should we use this minor form or no? I have no idea because we did not approve Lumetics to have a 5.1 minor form. And I have no idea what is on that form. Anybody?
I think I had some conversation with Paul about this, maybe,
Mm-hmm.
and then he was going to follow up.
Yeah, I'm not sure, Tammy, on that one. You might want to send Leanne in a question. I think you're right, Ruth. I remember that seeing emails coming back and forth about that. But if you want to send that into Leanne, we can make sure to follow up with you on it. Okay, I'm not sure if you're able to take this, if you want it to take this one or not from Whitney. It says if there's no specified size reported on the CT and PET imaging of a lung nodule, but an EBIS shows positive adenocarcinoma prior to the procedure, how do I answer the clinical T stage? There's no TX option, right? Let's go to 1810. So we're looking at this the T stage for lung cancer. So the patient, no specified size on CT and PET. The EBIS shows a positive adenocarcinoma. How do they answer T stage? Is there clear, or do you want this to go into the FAQ?
No, I mean, I would follow up with your physician and ultimately perhaps with your radiologist. They may be able to give you a T size if you ask for an addendum on your report. I've asked for many an addendum. My radiologists love me dearly. So you can always ask, go back to your clinical experts and ask for more information would be my suggestion, and see if they can give you that info. And if not, then send me an email or put it in an FAQ.
Great, thank you. And then Kurt, in response to that 5 points, I guess it's 5.21 minor form, says that he would guess that the minor form will not be harvested to STS, but used for internal institutional purposes only. Yeah, thanks, Kurt. I'm not sure. I have no idea what Lumetics is doing with that form, but we did not approve them to have any type of minor form. So we'll have to follow up if anybody, we'll have to follow up internally to find out where we're at with that. Thank you. And Aaron says, follow-up question from Laura on pylorus management and J-tube placement and CPT codes versus checking the box. Could I please talk through this? Could I please talk through this in more detail?
Sure. So we used to, under the procedures, there used to be a CPT code for intraoperative jejunostomy. That was the thing that we used to code all the time. When a patient had an esophagectomy, you would code the esophagectomy as your primary procedure. And then my secondary procedure was usually like intraoperative jejunostomy, and then sometimes I'd throw in the EGD too, right? But now intraoperative jejunostomy isn't an option anymore. The reason being that you're just going to check the box down in the esophagectomy section. Oh, can you please talk? That wasn't very clear. Sorry that I'm talking and you want to talk. I
Yep,
don't know how to make it. Can you
I
fix
think
it?
I did it. Yeah, just have to
Okay.
unmute yourself, Aaron.
Can you hear me?
Yes.
Oh, awesome. Thank you guys so much. So I just wanted to follow up more on Laura's thought and idea. And so for us, we always base our data and our querying based on the CPT code. So at our institution, we are still going to document that CPT code. We look at all the legacy data and we run data from multiple versions. We go back to the source, which is that CPT code. So now we're switching a version and now we're moving where the data might be at. So when we're querying all this data, we want to look at CPT code. Now you're wanting us to add some checkboxes, which are different variables. So I'd go back to Laura and say, what's best for your in-house reporting that you do in your database? So at our institution, we are going to document the CPT code because that is the source. And we might opt out and not check the checkboxes in this scenario.
I think you need to check the checkboxes though, because the STS is looking for the information to be in the checkbox section. They're not going to find it in your CPT code list.
Yeah, and we're doing the behind the scenes mapping between the harvest codes that were used for the procedures and now these new variables and the harvest codes within these variables. We'll be doing the mapping for those. So it's important to still complete these sections, but I get what you're saying about internally, you use those CPT codes and it's easier for you to query the data.
And so correct me if I'm wrong, the J2 placement, that is a billable CPT code, correct?
I don't know if it's done in conjunction with a procedure, if it's expected and you could bill for it or not. If it's two procedures done at one time, probably not. If it's a separate procedure, probably. But
Right.
yeah, I'm not 100% positive. I don't do billing. That's why I don't want to, I can't say for sure on that one. But my understanding is you can't bill for two separate procedures during one operation.
Well, there's multiple CPTs for one
Yeah.
operation, whether it be VATS lobe and lymphadenectomy and bronchoscopy and mediastinoscopy. So
Yeah,
we can have multiple.
I think those all fall underneath a DRG, right? So,
but we're not doing, so again, CPT is the source.
yeah.
So again, that's been the backbone, CPT and ICD-10s for thoracic. And so I feel like we're getting away from that backbone a little bit and we're adding multiple check boxes now. So specifically to the esophageal, now we got to check a box for neck approach, thoracic approach, abdomen approach.
Mhm.
Our six surgeons don't necessarily dictate that granular. And so again, we might not be checking those boxes. It's in the CPT code, right? If it's a thoracotomy or it's a VATS, that's all based off in the CPT is what I'm thinking.
Okay. All right, thanks for sharing. Anything to add to that, Ruth, or anybody?
No, I guess I would just say that the STS has always cautioned against using CPT codes from your EMR as your primary procedure, because the billing data has always been kept very separate from the quality data. So I would just caution against looking at what your billing coders are using and using that for what you abstract, which I know isn't necessarily what you were saying, but I just want to make sure that's clear.
No, and I greatly appreciate that, Ruth. I really do. But that at our institution, that is our gold standard. If it was billed to the patient, if we get audited, we're going back to what was actually done, not what an abstract or think was done. We go back to the service recognition in Epic and say, this is what truly was done and was billed to the patient. That is our source data.
Yeah, sometimes when I have done, I appreciate that, Aaron, but I can tell you when I was abstracting, I used to compare what was billed using the CPT codes, what came from our billing department off of what was actually performed on the patient. And there was, I had discrepancies monthly between the billing and what was actually done on the patient. So I think that's why we caution against that. And your site might be much different, and they might be very detail oriented to make sure, and they might have awesome billers, making sure that all of those CPT codes are correct. But as you know, CPT codes, they do update frequently. And there's changes, and sometimes people, might accidentally code something incorrectly on the billing side versus or not understand the operative report for what was really done. So that's, I think, why we caution against using that as the gold standard for all of the other sites. Your site might be different, but for most sites, I don't think it's as accurate on the billing side as we would hope.
Thank you. I appreciate the opportunity to speak. Thank you, guys.
Yeah. Thank you, Aaron. Thank you. Okay. Please clarify if cases will be excluded for when ECOG scores are missing for the new version. So the answer to that is no. The reason why it's not going to be, and I'll pull it up here. ECOG score, it's a required field, but we won't be excluding cases because we don't have an NA here. So there is a possibility that you will not be able to have an ECOG score. And so these would be left blank because we don't want you to guess at that. And so this is the one field out of all of the required fields where if it is missing, it will not prevent you from going into analysis. Anything to add on that, Ruth?
Nope.
Okay. So Mary says, and I'll give this one to you, Ruth. So it will not be wrong to both check the boxes and code J-tube and pyloroplasty.
Nope, that's fine. If you want to put in the J-tube and the pyloroplasty as miscellaneous procedures, you can put the CPT codes in. But you do need to check the boxes for sure.
Thank you. And then last question I have here is on the topic. You're welcome, Mary. Mary says, thank you, Ruth. On the topic of approach, when a patient has an Ivor-Lewis esophagectomy, laparoscopic, thoracoscopic, should we capture this on both sequence 2330 and 2340? Do you want to take that, Ruth? Or do you want her to submit it into the FAQ? I would say that we coded on both, but.
You're going to answer the approach questions accordingly to how the procedure was performed. I guess send me, if you have questions about a specific case, if you want to just send them to me, Whitney, that'd be great.
Thank you. And then is this only for the new version related to missing ECOG scores, this upcoming fall harvest 2021? I'm not 100% positive on that question. We'll have to check into that one unless somebody from iQVIA knows, or Ruth or Katie, or Melissa, if you know this question related to the ECOG score on the version 2.41. It was a required field. I just don't know if that required field was being removed from analysis.
It was a required field, and I think it was removed from analysis, but I think the difference is that data managers were imputing the value, and they've really, like this time around, the stance of the STS is don't, like if it's not in your document, don't come up with an ECOG score and put it in, right? So now, until the NA is available, it would not be excluded for 251, but it was from 521. It was from 241.
Great. Thank you.
Then that will stay the same.
Yeah, and unfortunately, I think because it was being removed, like Ruth just said, people were guessing at it or, trying to come up with their own score, and we really don't want that. So, okay. Any other comments, questions?
Carol, this is Katie. I just had one more comment to everybody regarding the status at hospital discharge. We talked a little bit about this regarding hospice discharge, and some might know this already, but if you have a case where your patient is discharged alive, but then later dies, even if it's after the 30-day, you now, in order to include a mortality date, they've made the mortality date for this version a child field to that discharge question. So say your patient dies like 90 days after, and you happen to go back and do follow-up on it, and you want to code the mortality, you have to change your discharge alive, last known status alive, to discharge alive, died after discharge, in order for you to enter the mortality date. So just wanted to mention that.
That's a great point, Katie. And to add on to that, one thing, so folks don't think that we're just looking at this discharged alive, died after discharge field to determine the definition of operative mortality. They are looking, when they do analysis, they are looking at the date of surgery, the date of discharge, and the date of death to confirm that that patient met the true meaning of operative mortality. That's a good point out. Thank you. For Elizabeth is saying, so it will stay the same and records will be excluded in regards to version 2.41. I have to double check. I believe that they are supposed to be excluded. I have to double check with what's going on at DCRI. And Melanie, I'm not sure if you have any update on this or not.
No, unfortunately, no. We would have to check with DCRI.
Yeah, sorry, Elizabeth. Okay. Anybody else? Yeah, Elizabeth, could you just send us an email so we don't forget to respond to you? If you could send it, you could send it to me. I'll put my email in. Thank you. Okay. Good call out on that last one regarding discharge status. And I think some sites do use that, as Katie was saying. I think some sites track all of their patients, especially when we were doing like the 5-year follow-up on those patients. If you found out the patient was expired, some sites were updating their mortality date because they like to keep track of those patients long-term. So that's a good thing. Katie did a great job pointing that out, that you have to go back and change status at hospital discharge in order to get to that mortality date field. Okay, so I don't think we have any more questions. Thank you, everybody, for joining. Ruth, any last words? Melanie, Joe, anybody from my STS team? Okay, thanks, Ruth. Thanks, Katie. Thanks, Melanie. Thanks, everybody. And I hope you have a great rest of the day.